Welcome to the NCLEX Review, where I help you review all the things you need to know for NCLEX. If you would like a copy of the study guide, you can find it on my website, blossomwithjessica.com. So let's talk about the endocrine system. So a quick anatomy overview is we have endocrine glands throughout our body, which are our adrenals, hypothalamus, ovaries, pancreas, parathyroid, pituitary, testes, and thyroid. Then we have something called metabolic syndrome. So this is 3 or more of the following factors are present, and it increases a patient's risk for stroke, diabetes, and cardiovascular disease. So abdomen obesity, high triglyceride levels, low HDL, and a fasting blood sugar greater than 110. So let's talk about endocrine disorders. So we have our hypo and hyper. So when we talk about hypo, pituitary growth hormone and gonadinoid hormone, we're talking about hypopituitarianism. And then when we talk about an increase of the growth hormone, it's hyperpituitarism. So let's compare the two. So hypo is a hyposecretion or one of more of the pituitary hormones caused by tumors, trauma, encephalitis, autoimmunity, or stroke. So we're talking about pituitary hormones, right? Because we have all these different endocrine glands. With hyperpituitarism, we have a hypersecretion of the growth hormones. Our signs and symptoms for hypopituitarism, so when it's low, is mild to moderate obesity, reduced cardiac output, infertility, sexual dysfunction, fatigue, low blood pressure, tumors of the pituitary that may cause headaches or visual deficits. And our nursing interventions are we may need hormone replacement, and we need to educate them on signs of hyperpituitarism because if they have too much medication, it can cause that. So when we talk about hyperpituitarism, our signs and symptoms include large hands and feet, thickening and protrusion of the jaw, arthritic changes of the joints, visual disturbances, diaphoresis, oily, rough skin, organomegaly, hypertension, arthrosclerosis, dysphagia, deepening of the voice, thickening of the tongue, narrowing of the airway, hyperglycemia, colon polyps, and colon cancer risk. So I think Tony Robbins has this. I don't know if you guys know who Tony Robbins is, but if you look him up, I think he has this, and you can see he's a very large man, large hands and feet. He's got a very big kind of jawline, and he has some really good talks. So nursing interventions, we're going to provide pharmacological interventions to suppress or block the action of the gonadotropic hormones. We're going to prepare the client for pituitary gland radiation, stereotactic radiosurgery, or hypophycectomy if planned. We're going to offer them pain relief and emotional support. All right, so now when we talk about the hormone ADH, posterior pituitary is the endocrine gland involved. What we're going to see is diabetes insipidus if it's low. So again, this is, let's just add hypo and hyper so we can see it. All right, so if it's low, we have diabetes insipidus. This is caused by stroke, trauma, and surgery. This is when the kidneys fail to reabsorb water. Signs and symptoms include a large amount of dilate urine, polydyspia, dehydration, low urine-specific gravity, fatigue, headache, tachycardia, postural hypertension. In our nursing interventions, we're going to monitor vital signs, monitor electrolytes, maintain fluid intake, may need an IV, monitor intake and output and weight. Now when we talk about syndrome of inappropriate antidiuretic hormone secretion, again, this is the hyper ADH, causes or trauma, stroke, malignancies, medication, and stress. Signs and symptoms are that it leads to a water intoxication and hyponatremia. Nursing interventions monitor for fluid overload, change in level of conscious, weight gain, hypertension, tachycardia. We want to monitor their neuro status, so looking for signs of that increased intracranial pressure. Monitor intake and output, monitor weight, serum osmolarity, urine-specific gravity. We want to restrict fluids, administer diuretics, and have them on seizure precautions. These patients will need lifelong glucocorticoid replacement. All right, then we have Addison's disease and Cushing's disease. So this has to do with cortisol, and this is from the adrenal gland. So we have Cushing's is going to be hyper, and Addison's is going to be hypo. So for Addison's, signs and symptoms are lethargy, fatigue, muscle weakness, gastrointestinal disturbances, weight loss, menstrual changes in females, impotence in males, hypoglycemia, hyponatremia, hyperkalemia, hypercalcemia, hypotension, hyperpigmentation of the skin. Then we have something called Addisonian crisis. Different color. There we go. And this is an acute adrenal insufficiency caused by stress, infection, trauma, surgery, or withdrawal from corticosteroids. Signs and symptoms are severe headache, weakness, hyponatremia, hyperkalemia, hypoglycemia. You get severe abdominal, leg, and lower back pain, irritability and confusion, severe hypotension or shock. And our nursing interventions are to administer fluids and glucocorticoids IV. Post-crisis, we're giving PO glucocorticoid, monitor vital signs, neurostatus, intake and output, maintain bed rest in a quiet environment. Patients with Addison will need lifelong glucocorticoids. During times of stress, glucocorticoids will need to be increased. So just an important fact. Then let's talk about Cushing's syndrome. So again, this is when we have a high level of cortisol. So this is a metabolic disorder resulting from chronic and excessive production of cortisol from the adrenal cortex or from the administration of glucocorticoids in a large dose for several weeks or longer, or from ACTH secreting hormones. So Cushing's disease, this is a metabolic disorder with increased secretions of cortisol caused by increased amounts of ACTH secreted by the pituitary gland. Signs and symptoms for both include muscle weakness and wasting. You'll see the moon face and buffalo hump, truncal obesity, hirsutism, which is masculine features in a female. They might get hair on their face, hyperglycemia, hypernatremia, hypertension, fragile skin, bruises easily, and striae on the abdomen, which is stretch marks. Nursing interventions, we're going to monitor vital signs and monitor intake and output. All right, so then let's talk about the thyroid. So again, we have, so for hypothyroidism, our T4 is low and TSH is elevated. We have decreases in the body's metabolism. Signs and symptoms are going to be lethargy, fatigue, weakness, muscle aches, cold intolerance, weight gain, dry skin and hair, constipation, edema around the eyes and face, bradycardia and cardiac enlargement, and sometimes a goiter. A lot of times you can think that this is like everything is slowing down. Let's do hypothyroid. Okay. So our nursing interventions are going to include monitoring vital signs and heart rhythm, administer thyroid replacement, usually levothyroxine, monitor for overdose on thyroid meds. So we're looking for signs of hyperthyroidism, instruct the client on a low-calorie, low-saturated fat diet. To go along with hypothyroidism, we also have something called myxedema coma. So we can see up here that one of these signs and symptoms was edema around the eyes and face, which is myxedema. A myxedema coma is due to persistently low thyroid production. We're going to see hypotension, bradycardia, hypothermia, hyponatremia, hypoglycemia, generalized edema, respiratory failure, and then coma. This is not good. We don't want this to happen. So our nursing interventions, if this happens, is to maintain a patent airway because our airway breathing circulation. aspiration precautions, IV fluid. We're going to give them that levothyroxine intravenously along with glucose. We're going to assess clients for temperature hourly, keep client warm, monitor for changes in mental status, and monitor for electrolytes and glucose levels. Now when we talk about hyperthyroid, let's do hyperthyroid. So for hyperthyroid, our T3 and T4 are high, but our TSH is low. It increases the body's metabolism, and this can be caused by Graves' disease. So signs and symptoms are irritability, nervousness and fine tremors, heat intolerance, weight loss, smooth skin, palpitations and cardiac dysrhythmias, diarrhea, exophthalmos, this is bulging eyes, hypertension, and goiter. So the way we can think about this is everything is speeding up. Our nursing interventions are going to include providing rest, administering sedatives, providing a cool, quiet environment, provide a high-calorie diet, avoid stimulants, administer anti-thyroid medication or iodine preparations, administer propranolol for tachycardia. If the patient has exophthalmos, so the bulging of the eyes, we're going to elevate the head of the bed, give them a low-salt diet, artificial tears, use dark glasses, or tape eyes closed at night because sometimes they're popping so much the eyelids won't close. Then we have something along with hyperthyroid called thyroid storm, and this is uncontrollable hyperthyroidism. We're seeing things like fever, tachycardia, systolic hypertension, agitation, tremors, confusions, delirium, seizures, and coma. And our nursing interventions include maintaining a patent airway, administer anti-thyroid medications, propranolol and glucocorticoids, monitor vital signs, and cardiac dysrhythmias. Now we're going to look at the parathyroid. So we have hypoparathyroid and hyperparathyroid. So for hypoparathyroid, we're seeing hypocalcemia and hyperphosphatemia, tingling of the and muscle cramps, a positive Terso's and Chauvet-Tex sign. We're going to see tetany, hypotension, anxiety, irritability, and depression. So we can see for a lot of these, there's some overlap with all the electrolytes and things like that, but a positive Trousseau's and Chauvet-Tex sign with hypoparathyroid, that's important to know because it's very specific. So nursing interventions, we're going to monitor vital signs, tetany and hypocalcemia, initiate seizure precautions, place a trach kit, O2 and suction at the bedside. They may need calcium gluconate IV. They may need vitamin D for enhanced absorption of calcium, and instruct the client on a high calcium, low phosphorus diet. When we talk about hyperparathyroid, we're going to see hypercalcemia and hypophosphatemia, fatigue, muscle weakness, bone deformity, skeletal pain, anorexia, nausea, vomiting, weight loss, constipation, hypertension, cardiac dysrhythmias, and renal stones. And our nursing interventions are monitoring vital signs, specifically blood pressure, monitor for dysrhythmias, INOs, and renal stones, administer furosemide to lower the calcium levels, administer calcitonin and phosphates and biophosphates. Okay, so let's talk about insulin and pancreatic disorders. So we have two types. We have type 1 diabetes and type 2 diabetes. Let's talk about insulin and pancreatic disorders. So the first is going to be type 1 diabetes. So this is an absolute insulin deficiency. They do not have any. If insulin is not given, fats are metabolized for energy, which leads to ketone production, which leads to acidosis. So signs and symptoms are polyuria, polydipsia, polyphagia, and weight loss. These are key to remember because this is what differentiates from type 2, because you're also going to have all of the same signs and symptoms that are in type 2, in addition to polyuria, polydipsia, polyphagia, and weight loss. Nursing interventions are to instruct the client to monitor their blood glucose levels before, during, and after exercise, and to provide insulin. Then we might see something called diabetic ketoacidosis. This is a life-threatening complication of type 1 diabetes. It is a sudden onset due to inadequate insulin doses, infections, or other stressors. In ketosis, there is Kussmaul's breath or Kussmaul's respirations, which is a fruity breath. This is a key sign. So just remember that. That goes along with DKA. We'll also see that polyuria, polydipsia, polyphagia, dry skin, sunken eyes, and coma. Diagnostically, what we're looking for is going to be urine ketones that are positive. Our serum pH is going to be less than 7.35, and serum glucose is going to be greater than 300, which is also a key, right? We're looking at those blood sugar levels. So our nursing interventions are to give IV normal saline first. So if you get a question, remember priority is IV normal saline first. We're going to do cardiac monitoring. We're going to monitor and correct electrolyte imbalances, short duration insulin through an IV, monitor vital signs, intakes and output, and monitor the client for signs of increased intracranial pressure. Then we're going to talk about type 2 diabetes. So this is a lack or resistance to insulin. There is enough insulin to metabolize fats and protein, but not carbs. We're going to see hyperglycemia, blurred vision, weakness, slow wound healing, and inadequate circulation to the feet. Our nursing interventions are to instruct the client with diabetes to monitor their blood glucose before, during, and after exercise, and provide insulin or oral medications. Then we're going to see something called hyperglycemia, hyperosmolar non-ketotic syndrome, or HNS. This is extreme hyperglycemia that occurs without ketone or acidosis, which is the major difference in DKA. It's usually seen in patients with type 2 diabetes. That's because we know that they have enough insulin to metabolize fat, so you're not going to see those ketones. Signs and symptoms: gradual onset due to infection, stressors, or poor fluid intake. Neurological symptoms such as lethargy, coma, might see dehydration with increased thirst, electrolyte loss, and also the same symptoms as DKA. So we want to remember these are the differences, right? We always want to remember the differences. We don't want to have to memorize a bunch of information twice. So nursing interventions are similar to DKA interventions. Correct the IV normal saline first, correct electrolyte imbalances. Insulin replacement plays a less critical role than in DKA, and rehydration alone may fix this. All right, so let's discuss blood sugars. So we have hypoglycemia, which is a low blood sugar, and hyperglycemia, which is a high blood sugar. So for hypoglycemia, we're going to see things like cold, clammy, pale, irritable, weak, diaphoretic. For a moderate hypoglycemia, we may see mental status changes, confusion, irritability, headache, slurred speech. And for severe hypoglycemia, they'll be disoriented or loss of conscious and also seizures. Our nursing interventions include checking their blood sugar. If it's less than 70, we're going to administer 15 grams of simple carbs or half a cup of juice. Then we recheck the blood sugar in 15 minutes. If it's still less than 70, we want to give another 15 grams of simple carbs or half a cup of juice. Then we will recheck again in 15 minutes. If it's still less than 70, we want to administer 25 to 50 mLs of 50% dextrose IV, or we can treat with 1 milligram of glucagon sub-Q or intramuscularly. After the blood glucose has recovered, we can have the patient eat complex carbs and a protein snack. And if the patient has an altered mental status, we're going to start with the injectable glucagon. Then for hyperglycemia, we're going to see things like the patient's going to be hot and dry, have polyphagia, polyuria, polydipsia, blurred vision, and that fruity breath. And again, that diabetic ketoacidosis and hyperglycemic hyperosmolar non-chaotic syndrome. And we can see details of that in our previous section we went over. Now we're going to talk about types of insulin. So first we have rapid acting insulin. So this is our Lispro, Aspart, and Glulisine. These have an onset of less than 15 minutes. They peak at 1 to 2 hours, and they have a duration of 3 to 6 hours. Then we have our short acting. This is just our regular insulin. Its onset is 30 to 60 minutes with a peak in 2 to 4 hours and a duration of 6 to 10 hours. Then we have our intermediate acting. This is our NPH. This has an onset of 2 to 4 hours, peaks 4 to 8 hours, and a duration of 10 to 18 hours. And then we have a long acting, which is our Glargine or Detamir. And this onset is 1 to 2 hours. It has no peak, and the duration is up to 24 hours. And you do want to remember your insulins. You will probably get a question about insulin. Then we have something called Dawn phenomenon. So this is reduced tissue sensitivity to insulin causing pre-breakfast hyperglycemia. Our nursing intervention is to increase the client's insulin dose or change in scheduling the insulin time. Then we have Somogyi's phenomenon. This is normal or elevated blood glucose levels at night. Then we see hypoglycemia at 2 to 3 a.m., causing an increase in counter-regulatory hormone. And by 7 a.m., due to this hormone, the glucose levels rebound and are increased. Signs and symptoms are early morning headache, night sweats, or nightmares. Our nursing intervention is to decrease the client's insulin dose and increase a bedtime snack or both.
If you would like a copy of this study guide, you can find it on my website, blossomwithjessica.com.